it's not a question of, the place from where they are, shifted. No. Even the hospitals within the, city, there is a delay in referring these patients.
I agree, sir.
Okay. So my plea is that if these babies are, sent us as early as possible, I think we can give a better outcome. Okay. Regarding my question, I have two questions. One question is, you said Hirschsprunger's disease, which is diagnosed in the neonatal period, is to be delayed as long as you want. How much time you want to wait?
I did not say, sir, as long as possible, but
sir,
there are many babies who drastically respond to digital rectal examinations and enemas, so washes. The baby's general condition is not good. So in those babies, if the child is decompressed and there is a significant decrease in the girth, then we can delay it for few days, I think maybe. But ultimately, the child would need a diversion.
No, but actually, why did I ask this? No. Why did I ask this question? I have already done, I think it's the highest series, neonatal transanal pull-through. Already I have completed 100 cases.
Sir, I am aware, sir.
Okay, I have already completed 100 cases. And these patients, luckily, they are diagnosed in neonatal period. The safe period is, I suppose, 3 months till the stools are,
correct. The bowel is not direct.
Yes. Early, it is too early because there is a apprehension, and other things. But that is, in fact, there are some points against that. They may have some sort of what you call the cough syndrome. But with my, when we started doing more and more cases, we have overcome that issue also by just dividing the cough and the posterior side. It does not cause any damage. My other question is, you said that because you started with your CDH, and you said that I can wait 6, 7 days. Yes, of course, it's a medical emergency, so we have to stabilize. So, what point of time is it that only you manage it on a conventional, ventilation, or you have something more in the hand? Right?
Sir, MAPC is now equipped with high frequency oscillated ventilation also, and most of my residents can do it. But pre-operatively, post-operatively, if the conventional ventilation fails, then we switch over to high frequency oscillated ventilation.
Thank you. Any question from
And you know better, sir, that the neonatologists know better that now there are nitric oxide delivery systems. And so that is also you can.
Anybody from the house? Any question, please?
Yes, many of these babies have been operated and post-operatively has been put on conventional, could not, because of the pulmonary hypertension, switched to high frequency oscillative ventilations also. But pre-operatively, if you ask, then yes, maybe yes. We have done high frequency ventilation, then switched back to conventional, and child improved. No, we did not operate any babies on a high frequency. It is always conventional ventilation. We have never operated intraoperatively. It is never a high frequency. It is very difficult to monitor. It is very pre-operatively was babies. Pre-operatively, I said that briefly, and then back to conventional ventilation.
No, the rule is simple. You have to stabilize. You cannot shift them to treatment. Whether it is conventional or whatever, unless patient stabilize, you cannot. One more question from this side, please.
From a neonatology perspective, just one comment about CDH. Despite best of therapies, whether it is INO, ECMO, survival of CDH is still not optimal. We are struggling, most of us are still struggling. So whatever you do is for stabilization of the babies. That is the best strategy a neonatologist can apply to keep them sedated, take care of PAH. Only once you are stable, then operate. Otherwise, none then, even INO, ECMO have not worked as well as they worked in other.
You are correct. Overall, the outcome is
still not.
Yes, of course. If there is no other question, you want to?
Yeah, I think Dr. Srinagar has very well covered the topic. The idea is to improve the neonatal mortality rate. Actually, knowing the things from the neonatologist point of view, So doing the counseling with the parents, that it is not only a surgical problem like in CDH, there is also pulmonary problem also, which due to which patient can linger on. So these are the finer details which the neonatologist should be knowing about and counseling the parents accordingly, so that telling the parents that ये तो surgical case है बस ये तो surgeon ही करेगा. I think a lot of responsibility lies on the shoulders of neonatologists also. I think that was an enlightening talk by Dr. Sudhir.
Thank you, sir.
Thank you, sir, for this remarkable session. Our chairpersons for the session about hypoxemic respiratory failure, challenges and management are Dr. Gaurav Gupta, Dr. Anurag Tomar, Professor and Director, NIMS University, Jaipur, Dr. T.S. Randhawa, Consultant in Jalandhar, Dr. Falguni Padi, Associate Professor and Head, All India Institute of Medical Sciences, Raipur. Joining us as our next speaker is the renowned Dr. N.S. Kabra. I request the respected chairpersons to kindly introduce the speaker.
Now we have come to a topic which is very much consistent and in line with the theme of this conference, and which is the aim and target of all practicing neonatology, is an intact neonate survival, and hence an intact child, intact adolescent, and intact adult, and hence intact nation. To dwell on certain aspects and damages of asphyxia to a particular system, we have amongst us Dr. Nandakishore Kabra sir, who is DM Neonatology, Director of NICU at Surya Hospital, Mumbai, has many publications in the index journals, many lectures, reviewer for Cochrane National Group, organizing executive for IAP NeoCon 2015. His neonatal critical care is special area of interest, and though people since ages have been labeling it as birth asphyxia, but I will call it as a perinatal asphyxia is a better term, because then most of the time neonatologist or the resuscitating team that is bearing the brunt once it comes, because they think everything was fine till child was born, something went wrong at the time of the birth. Over to you, Dr. Kabra sir, please. Thank you.
Good afternoon. At the very outset, I'd like to thank the organizing team of North Zone NeoCon, NNF-J&K, and Dr. Shaukat, who happened to be one of the very close and dear students at Surya Hospital, Mumbai. Greetings from Surya Hospital. So, what we are describing here is the cases that we see in day-to-day practice. A 39-week, 3.18 kg male, 28-year-old primary, otherwise uncomplicated course, everything looked good. Cesarean section at 39 weeks because non-reassuring fetal status, meconium stain amniotic fluid, respiratory distress, should take to a close by NICU, chest X-ray was done, meconium aspiration, but baby looked fine in nasal prong oxygen. And things went well for 30 hours, and then suddenly baby crashed. The saturation dropped to 70, and then you have a panic call for shift. Baby gets intubated, ventilated, and when you see the blood gas with pH of 7.25, CO2 of 50, oxygen of 40, and 76% saturation, and you do a bedside echo assessment, and you find that the heart looks structurally normal. There is a PFO with right to left shunt, and there is tricuspid regurgitation. Pulmonary pressure estimated at 68. There is no PDA. LV and RV functions are compromised. So we know that we are in a situation where we have to be really ready with facing a tough baby who is going to give lots of problem, and you may need to be ready with lots of support. So before we get into the depth of things, just first thing is to understand the basics. The term hypoxemia means less pressure of oxygen in the blood, whereas hypoxia means less delivery of tissue to the oxygen. Sometimes, although we use it interchangeably. What we measure in the blood gases is oxygen pressure, and we should use word hypoxemia. Now we know that in room air at sea level, the partial pressure of oxygen is about 150, and when you breathe in this gas, and when it reaches alveolar, the pressure of oxygen drops from 150 to 100 because of presence of carbon dioxide there. And from there, the pulmonary vein, which are actually like arterial saturation is, the PO2 is 80 to 95, and when it is returning from the pulmonary vein, which is like a venous circulation, the PO2 is 40. And normally in healthy situation, this alveolar to arterial gradient is about 5 to 20. But whenever there is any decompensation, this gradient is going to go up. So earlier we used to use the term persistent fetal circulation, then we moved to use the word PPHN, which is one of the most major difficult to treat clinical problems in neonatal intensive care. The hallmark of this problem is sustained increase in pulmonary vascular resistance that leads to decreased pulmonary blood flow, and that causes persistent hypoxemia, which may be very labile. Generally, worldwide literature, if you see, it occurs in 2 to 4 per 1,000 live births, and the mortality may be as low as 5% or as high as 20%, and even higher in some centers where you do not have support systems in place. But you are also worried that these children, when they grow up, they are not going to do that well. The working definition of pulmonary hypertension: failure of the neonatal postnatal fall in pulmonary vascular resistance, which leads to persisting right to left shunt across the fetal channels, and that results in hypoxia. It is an oversimplified definition of a complex problem, and in many babies, the major shunt is occurring at not occurring at the PF or PD level, but at the intrapulmonary level. All of us are familiar with the fetal circulation, wherein you know that the placenta is working as the organ for oxygenation, and lungs are not doing the job. Only 10% of the cardiac output goes to the lungs. So following birth, with first few breaths, you establish functional residual capacity, the surfactant is secreted, and the cord is clamped, and with this clamping of the cord, there is increase in the systemic resistance. This leads to rise in the PO2 that causes fall in pulmonary vascular resistance, and that leads to increased pulmonary blood flow. And this increased pulmonary blood flow increases pulmonary venous return, that returning to the left atrium, and the LA pressures starts to rise, that causes closure of the foramen ovale functionally, and increased pulmonary blood flow as well as increase in the partial pressure of oxygen closes the duct. So whenever there is problem with transition from fetal to neonatal life, this whole sequence gets disturbed. So the PPHN can be primary or secondary. Primary means the problem is at the pulmonary vascular level structurally. It accounts for 10 to 20% of all cases of pulmonary hypertension, and largely etiology is idiopathic. It is associated with some maternal condition and also can happen with polycythemia and fetal anemia. But what we see in practice is 80 to 90% cases of PPHN are secondary to the pulmonary parenchymal disease like mechanism aspiration or RDS, things like that. Or it may be because of congenital diaphragmatic hernia and similar conditions. And these are the situations which practically you would see in your day-to-day life. So what actually happens is, first of all, there is increased pulmonary vascular resistance, so there is less blood flow, there is collapse of the alveoli. Now with these two things happen, the shunting may happen at the intrapulmonary level, where the blood going from the pulmonary vein, pulmonary artery is not oxygenated and is returning to the left side without proper oxygenation. And sometimes the shunts may be at the level of duct as well as the PFO. If we treat in time, then the outcomes are likely to be good. So what is exact pathophysiology and cascade in this? So you have increased pulmonary vascular resistance that affects the right ventricular afterload. So that causes right ventricular systolic and diastolic dysfunction, and then shunting at the level of PD and PFO. This affects right ventricular output and right ventricular feeling, and that leads to decrease in the pulmonary blood flow, and that causes decrease in the left ventricular preload, VQ mismatch, LV dysfunction, and decreased left ventricular output, and eventually it ends up as systemic hypoperfusion and shock-like situation. So what are the common signs and symptoms? So if you just remember acronym babies, big blue-looking baby with fast heart rate, breathing rapidly, with inadequate labile oxygenation, with increased respiratory effort, and the oxygen saturation gradient of 5 to 10% is what classically you would see. Chest X-rays may be very variable depending on underlying pathology, right from transient tachypnea to aspiration to diaphragmatic hernia. But the gold standard for diagnosis of pulmonary hypertension is doing a echocardiography. And what actually you look in the echocardiography is that the right ventricle, the feeling of that is affected. There is increased pulmonary vascular resistance that causes dilatation of the right ventricle. Contractility is affected. There is shift of the septum from the right to the left. There is also tricuspid regurgitation that causes dilatation of the right atrium. There is opening of the shunt at the level of PFO and PDA, and eventually because of decreased blood that is returning to the left side, the left ventricle also starts to back up and starts to fail, leading to left ventricular failure as well. Just to estimate the pressure, you have standard equation, and which those people who do the regular echocardiography are aware of. But when you are just looking eyeball, if you find that the septum looks like the left ventricle looks O-shaped, that means you are reasonably well. If the septum looks flat, that means there is already moderate pulmonary hypertension, and the left ventricular pressures are also dropping there. And if there is a bowing of the septum into the left ventricle, that means left ventricular feeling is compromised. Crescent